Vice Chairman Dr. Shah for giving me the opportunity to present my views on the subject. Troubleshooting in PHACO. Now it's like a master mechanic trying to solve all your problems. And I'll try to cover the topic as much as possible, starting from the basics to the most advanced stage. Even though there may be a repetition of the certain topics or certain views, but let's go to the point. I have no points of interest in the products mentioned in the presentation. Now, after the previous speakers, I hope all of you have learned PHACO dynamics. Means the vocabulary, probability, duty cycle, surge. All those words may sound Greek and Latin initially, but you will have to learn. Today, every ophthalmologist has aspiration to be the best PHACO surgeon, constantly performing clear cornea, astigmatic-free circle of pupil with well-centered IOL, and happy patient and happy surgeon. Irrespective, they might have done lots of small incision cataract surgery. The biggest hurdle is the PHACO training, and there comes the fear factor. Moment the PHACO handpiece comes in your hand, the fear factor should not come. The PHACO nightmares and the difficulties of PHACO surgery are both known to junior as well as the senior ophthalmologists alike. I always compare doing a PHACO surgery to driving a brand new Mercedes Benz or a Audi or a BMW. If you don't know how to drive it, you're going to have disastrous accidents. So let's come to the PHACO troubleshooting. Starting with the pre-operative, and then we go to the intra-operative. What are the pre-operative? Before you start, even though your scrub nurse may be preparing the PHACO machine, the primary and tuning is the most important aspect about the starting before you start your PHACO surgery. Establishing a fluidic circuit by connecting irrigation and aspiration tubings, PHACO handpieces, and test chamber. Removal of the air from the tubings is very vital, otherwise it will come in your way. I wish I can show every bit of this in my video, that when the air bubble comes, how difficult it is for you to remove that, Testing, because of you have not taken care of this aspect. Testing irrigation, testing vacuum build-up, testing venting and reflux. Before you start, even if your your scrub nurse has tested everything, testing the handpiece in your sleeve, in the test chamber. In case of a priming failure, what you should first check the display message on the PHACO machine. It will guide you properly. Check the tubings are installed correctly and the latches are closed properly. For the pump rotation also you must check to the chamber for leakage. There could be a small tiny leakage which may not be giving you a proper priming. Reinsert the cassette or tubings and then reprime it. Reboot the machine in case it still doesn't prime properly. Don't start the surgery. Don't give even I would say anesthesia or topical. I would suggest don't even take the patient inside, because all those things are happening in the OR in front of the patient lying down over there, and he's listening to everything. It's not good. And if it still fails, call the service engineer. What could be the cause of tuning failure? It could be a loose connection to the machine, loose tip or incorrect tip load, tuning, you are doing the tuning in the air, that can be the possible reason, the faulty handpiece. And if this is happening, use the PHACO tip, the solution, tighten it again, retune it, do not over tighten it. Even sometimes the over tightening also can cause a problem. Replug the handpiece and retune it. If it still fails, change the handpiece. I hope all of you have an extra handpiece in your OR. Ensure the adequate irrigation. Ensure the correct bottle height. That's very vital, as Dr. Armansal has told you. Rule out thinking of the tubing. I've shown you over there that the thinking of the tubing can be possible. Check that infusion lock in drip set is open. Sometimes we are in the hurry up to do the things, the scrub vessel may not have opened up the lock. Insert the needle in the DSS bottle to ensure free irrigation flow. Check the infusion bar in your machine. Now we come to the intra-operative troubleshooting. I again say, we all know now all the words, the duty cycle, US ultrasound power, etc. So I'm presuming that you know all those words properly. Insufficient ultrasound delivery, increase the ultrasound power or duty cycle. Still node cutting, change the phaco tip. No aspiration but vacuum builds up without visible occlusion. There may be a fragments in the phaco tip, could be the handpiece or in the tubings. Move phaco tip to center, away from danger area, apply the burst of ultrasound. So burst, since you know burst ultrasound, I presume that you know what I am asking you to do. Still blockage, withdraw the phaco tip from the eye, get the test chamber filled with the fluid, increase the vacuum and ultrasound, flow pedal till vacuum drops. Still there is a blockage, flush the aspiration, port of the handpiece together with the phaco tip, check that tubing are not bent or pinched. Believe me, all of you have to know this. Don't leave it to your assistant or your scrub nurse. You have to know how to connect to the phaco handpiece and how to remove the blockage. Still the blockage, change the tubing. The word followability you know already. Not enough followability means fragments are not coming to the tip easily despite going close to the fragments. Increase the flow rate. Fragments coming readily but vacuum builds up slowly. Ensure proper occlusion. Use pulse or burst mode. Fragments occluded at maximum vacuum but falls up quickly. This is called checker. Upon manipulation or application of ultrasound. Increase the present vacuum. Reduce the ultrasound power or duty cycle. Fluctuation in chamber depth is a very common problem. We should not have with the newer machines. Of course, we have almost solved these problems. Check irrigation tubing is tightly attached. Check the tone sleeve or if it is there, then please replace it. Fluctuation in chamber depth. Rule out excessively retracted sleeve irrigation from the side port outside. Again, the fluctuation in chamber depth, one of the reasons is check if incision is too tight, please enlarge, reduce flow rate and increase the bottle height. If you know if we are operating in hyperopie, that could be one of the reasons for shallow empty chamber. There could be a vitreous upthirst and could be angle closure glaucoma. Increase the bottle height depending on the shallowness of the empty chamber. Lower the flow rate. Use the liberal viscoelastic and start the IV monitor if it is necessary. The sudden collapse is one of the disasters we should always avoid. Keep your staff alert because water runs out of the BSS and suddenly there is a collapse of the empty chamber. As Dr. Arban has already told you what is a surge. This is some graphic I am showing you what is surge situation when outflow of the fluid from the eyes exceeds the inflow even for just a fraction of a second. This is graphical animation and I am just showing exactly the video. What happens, this is one of the most, I am showing you the surge phenomenon. This is very, very shocking and gives you a heartburn. I always say when these things happen, I lower my age by 1 year. This is happening due to the occlusion rate. You notice the surge phenomenon happening. So, what is the surge prevention? Already it has been covered. Bottle height is a prime important thing. High-end machine, use of ACM, positive pressure irrigation. cruise control, dual linear foot pedal, fusion fluidics, use of proper non-collapsible tubing. So I'm not going to talk anything more because it will be explained by Dr. Armansar very beautifully. This was so we explained to you, cruise control. This really helps us in surge prevention. Problem with the surge is the loss of confidence of the surgeon. Inability to use high vacuum, longer time for surgery, higher chance of complications like PCR, endothelial damage, small pupil and iris damage. So, aftercare of the PHACO machine is also equally important to prevent any mishap happening during the PHACO. Don't over-autoclave because over-autoclaving can force endothelial case to be expand and allow moisture to enter and cause hand-piece failure. Allow proper cool down. Flushing the handshells immediately with room temperature fluids can cause crystal to crack. Allow the handpiece to cool to room temperature before flushing any fluids in it. Do not use for more than 5 to 10 surgical cases. Observe the tip under the microscope for signs of flaking, blemishes, discoloration and cracks. Discard damaged tips. Though I must humbly accept I've used maybe 50 times and I have not found any problem, but after checking the tips I always find out whether I need to change the tip or not. Keys to solving problem solutions situations are: do not be ignorant or have a lack of concept of eco-emulsification. Remove the fear factor. Understand the machine very well. Identify the problem by observing movements of fragments, entry segment and machine problems. Drawing the correct conclusion based upon the observation. Taking appropriate measures to remedy the situation. Maintenance and care of machine and accessories. Thank you for your kind attention.